Therefore, today's webinar is very important, such as pathophysiology of NAFLD, how to help the patients and treatment, and so on. And I hope it will be helpful for the many of NAFLD patients. I will introduce today's webinar's moderator. Since you are all familiar with, I briefly introduce host moderator, Professor Diana Powell from Fatima University Medical Center of Philippines. She was past president of APASL and the past president of Philippine Society of Gastroenterology. And second moderator, Professor Grace Wong, the Chinese University of Hong Kong. Professor Wong is the one who is always invited for NAFLD conference. And third moderator, Professor Yonggyun Cho of Songyungan University of Korea. He is chairman of a NAFLD study group of CASL. So first introduce Professor Yonggyun Cho about the presenters. Professor Cho, please.
Please unmute. Professor Cho, please unmute.
Professor.
Sorry. Yes. Hello, everyone. Thank you for joining on APASL webinar today. It is a great honor to have a discussion with excellent hepatologists in webinar. I'm Yonggyun Jo from Songyun University, Korea. Yes, today, as Jim Mo Yang President already mentioned, today's the topic is the update of the management of NAFLD. In particular, we focus on the lean NAFLD, which is particular interest recently. As you know, the lean NAFLD is a relatively new concept, and there are significant interest in understanding the difference in pathophysiology, prognosis, and management compared with obese NAFLD. Especially in Asia Pacific area, a significant proportion of patients are lean and remain at risk of development hepatic and extrahepatic manifestation complications. However, the entity remains poorly characterized and understood. In this aspect today, this topic is meaningful and important. Okay, I will tell you the sequence of the webinar. In the beginning, the lean NAFLD patient case will be presented, and at the end, the summary and wrap-up will be done by Professor Hae-Won Lee from Yonsei University in Korea. And after that, we will have a discussion time. With that time, panelists and chairman, person speakers, and together. And we have a Q&A time in that time. 4 topics will be presented, and each will have a 20 minutes of presentation. We will have a question and answer time in discussion time after all presentation is over. So let's get started the webinar now. First, I introduce the Hae-Won Lee from Yonsei University in Korea. She will give a case presentation. Professor Hae-Won Lee, give us the case presentation.
Thank you, Chairperson, for your kind introduction. I will share the slide first. Hello, everyone. Before I begin, I'd like to thank the organizer for giving me this opportunity to share my cases in this special APASL webinar. Today, I'm going to present 2 cases of non-alcoholic fatty liver disease. I have nothing to declare regarding any conflict of interest. Let's start with the first case. A 55-year-old Korean female was referred to our liver center because of persistent liver enzyme elevation for the past 6 months. She is 160 centimeter tall and weighs 60 kilograms. Her BMI was 23.4. She was diagnosed with Sjogren's syndrome 10 years ago. She does not drink alcohol and is a non-smoker. When we examined her blood test, AST and ALT was elevated as 178 and 270 respectively. Gamma GT was also elevated as 109. The other laboratory tests were within normal limits. We also went through an ultrasonography. The parenchymal echogenicity of liver was moderately fine and bright without space-occupying lesion. The transient elastography showed 305 of CAP score and 12.5 kilopascal of liver stiffness measurement. Through FibroScan test, severe steatosis accompanied by fibrosis was suspected. Thus, liver biopsy was performed. The pathological findings showed that steatosis was 6 to 33%, lobular inflammation was 2 to 4 foci per 200 times filled with prominent ballooning and stage 2 fibrosis. The total NAFLD activity score was 5, that was considered diagnostic of non-alcoholic steatohepatitis. Based on these results, we assessed the patient has non-alcoholic steatohepatitis with BMI less than 25. The importance of lifestyle intervention was stressed to this lean patient. Let's take a look at the second case. A 54-year-old male was referred to our liver center due to fatty liver disease, which was found during his health checkup. He is 178 centimeters tall and weighs 99.6 kilograms. His BMI was 31.4. He has hypertension and diabetes and was on medications. Because of WPW syndrome, he got ablation treatment in 2013. When we checked his blood test, AST and ALT was slightly elevated as 40 and 62 respectively. Gamma GT also showed elevation as 100. In addition, he has abnormal lipid profiles with total cholesterol 270 and triglyceride 488. Fasting sugar was 168 and hemoglobin A1C 8%. We also ran ultrasonography. The parenchymal echogenicity of the liver was moderately fine and bright without space-occupying lesion. The transient elastography showed 351 of CAP score and 7.4 kilopascal of liver stiffness measurement. When MRI liver fat quantification was evaluated, 22% of the liver showed diffuse fatty change, which reflects moderate fatty liver. Based on these test results, we assessed that the patient had non-alcoholic fatty liver disease with obesity. Lifestyle modification was recommended as well for weight loss. However, he had a hard time losing his weight because of his long-established lifestyle. At this time, I'd like to ask key questions to the speakers and all attendees. First, what are the treatment options for lean NAFLD patients? Second, how to treat obese NAFLD patients who have difficulties in changing their lifestyle? Third, what is the current status of clinical trials associated with NAFLD treatment agents? I'm really looking forward to following talks tonight. I'll be coming back after all talks are finished. Thank you so much for your attention.
Thank you, Professor Helmy. I didn't mention I mentioned about Helmy, Professor Helmy. She is a rising star in Korean interest NAFLD group. So he many good papers making and good studies about NAFLD in progress. Thank you so much. Last after the session, she will summarize the case to us. Let me introduce first speaker, Professor Won Kim. It's Seoul National University. He will give a talk titled Pathogenesis of Obese versus Non-Obese NAFLD. Professor Won Kim. Is it online? Professor Kim, can you hear me?
Yes.
Yes. it's time to your presentation.
Yeah, can I share my slide with you? Well, hold on, please.
I can see your slide.
Okay.
Okay. Okay. Let's go on, please.
Okay. Can you see my slide?
You cannot see the slide.
I cannot play my slide with slideshow because my voice was already recorded with my file. So my voice was broken with this file. So I can I should present my slide with this. So please understand my situation. And can I start my presentation today?
Okay.
Thank you. Thank you, Mr. Chairman and organizers. I'm really grateful to the leadership of APASL for asking me to participate in this really terrific program.
Professor Kim, your slides I cannot see. So
Really?
how about your presentation last time? Just so okay, okay, I can see your slide. Yes.
Okay.
Okay. Okay.
Yeah. I would like to talk about pathogenesis of obese versus non-obese NAFLD. Today, a majority of studies have found focus on Western obese NAFLD population. Relatively, there is a lack of research on the characteristics of Asian NAFLD. However, currently, Asian NAFLD as well as Western NAFLD has become a main global public issue. As shown in this slide, the global prevalence of NAFLD is around 25% among general population. It varies among different regions and different ethnicities. The main factor contributing to this difference in prevalence of NAFLD is genetic predisposing factor. The minor allele frequency of PNPLA3 is 25%, but half of East Asian population, including China, Korea, and Japan, carry risk alleles. This may account for high prevalence of NAFLD among Asian population despite the relatively lower BMI. So the basic research for the development of diagnostic biomarkers or new drugs related to NAFLD would be multi-omic study. We conducted multi-omics analysis using huge biopsy-proven NAFLD codes and biobank in our institute. In our Brahme Medical Center, we enrolled 728 subjects with biopsy-proven NAFLD or no NAFLD controls in the prospective cohort at Brahme Medical Center. Among these, 18% were non-NAFLD controls, 42% had NAFL, and 34% had NASH. This cohort has three important features. First, the clinical and metabolic profiles of this cohort were extensively secured. And of course, pathological data was also well established because it was a pathological cohort. Finally, since human samples were obtained together in this cohort, it was possible to study the various kinds of omics through them, such as genotyping, epigenetics, transcriptomics, single-cell RNA sequencing, proteomics, metabolomics, and microbiome analysis. In summary, It can be called a well-characterized clinical pathological omics data course. So here is what I'm going to tell you today. First, I want to talk about the risk of fibrosis in obese versus non-obese NAFLD. Okay, we classify the NAFLD. We classify NAFLD into two phenotypes: obese versus non-obese, according to BMI 25, Asian ethnicity-specific criteria cutoff of obesity. Among a total of 542 Asian patients with biopsy-proven NAFLD in our courts, 410 had obese NAFLD, whereas 132 had non-obese NAFLD. Of the non-obese NAFLD patients, 40% had significant fibrosis, and 20% had advanced fibrosis, which were comparable to obese NAFLD. Among Asian obese NAFLD subjects, BMI was an independent risk factor for significant fibrosis, as usually shown in Western NAFLD population. On the contrary, among Asian non-obese population with NAFLD, visceral adiposity, as assessed by visceral adipose tissue area, was an independent risk factor for significant fibrosis. As all of you know very well, metabolic health status as well as obesity play an important role in the pathogenesis of NAFLD. In this context, we previously reported the association between body size and metabolic phenotype and NASH and significant fibrosis among our biopsy-proven NAFLD cohorts last year. First, we categorized study subjects into obese versus non-obese according to BMI, and then subdivided them into metabolically healthy and unhealthy status according to the absence and presence of metabolic syndrome. In non-obese NAFLD subjects, metabolic syndrome significantly increased the risk of NASH by 2.3 times compared to no metabolic syndrome in terms of odds ratio, whereas in obese NAFLD subjects, there was no significant difference in odds ratio according to metabolic status. These findings were also true for significant fibrosis as a main outcome variable. In non-obese NAFLD subjects, metabolic syndrome significantly increased the risk of significant fibrosis by 1.7 times compared to no metabolic syndrome in terms of odds ratio, whereas in obese NAFLD subjects, there was no significant difference in odds ratio according to metabolic status. These results suggest that such metabolic status may play an important role in the histological progression of non-obese NAFLD rather than obese NAFLD. Second, let me talk about the association between several NAFLD related major SNPs and histological stability of NAFLD in Asian NAFLD population. BMPL3 and TM6F2 are the most well-known major SNPs as a risk variant of NAFLD. The prevalence of Asian NASH and significant fibrosis was significantly increased in GG carriers compared to CC or CG carriers, independent of insulin resistance as shown in the upper panel. An additive model for BMPL3. In addition, the prevalence of Asian NASH and significant fibrosis was also significantly increased in CTTT carriers compared to CC carriers, independent of insulin resistance as shown in the lower panel, a dominant model for TM6SF2. Currently, There is no available non-invasive biomarker for NASH. So we tried to develop a novel pathogen risk scoring system based on genetic and clinical factors to determine the risk of NASH in Asian patients with NAFLD. PNPL3 and TM6F2 genotypes, diabetes, insulin resistance, CRP, and AST level are incorporated into this novel NASH PT score. The diagnostic performance of this NASH PT score was approximately 0.86 in the discovery code and 0.79 in the replication code, which was significantly superior to the existing NASH scores or health score. We also developed an individualized pathogen risk score to identify NASH in Asian virus-proven NAFLD patients. This study was conducted by Chinese NAFLD study group for discovery and by our Korean NAFLD study group for validation. This new predictive model includes PNPLA3 and HSD17B13 genotypes, the sex, metabolic syndrome, insulin resistance, and AST level. This slide shows the nomogram for calculating this score and the diagnostic performance of this score to predict NASH and the discovery, replication, and validation codes. We also analyzed bulk liver tissue expression quantitative trait loci, so-called EQTL, using our Brahman NAFLD codes and biobank. We selected a novel target gene, so-called AGXT2, and performed the functional validation of AGXT2 in cell and animal experimental models. If the AGXT2 gene was knocked down, ER stress occurred in hepatocytes, leading to fibrogenesis, recapitulating human NAFLD phenotype. On the contrary, diet-induced NAFLD phenotype was rescued by AGXT2 overexpression in a gain-of-function experiments. Most interestingly, the risk allele of AGXT2 was most frequently found in East Asian population, reaching approximately 60 to 70% compared to European or African population. Next, I'm going to compare metabolomics, including circulating lipidomics and bile acid profiling between Asian obese and non-obese virus-proven NAFLD patients. All populations were stratified into non-obese and obese subjects and then analyzed to identify the different lipidomic profiles between non-obese and obese NAFLD patients. The characteristic alterations according to histological severity of NAFLD were detected in several lipid classes, including diacylglycerol, triacylglycerol, and sphingomyelin. The changing tendency in glycerolipids, including DHA and TAG species, was a little bit different between non-obese and obese groups. The concentrations of saturated sphingomyelin, such as sphingomyelin, acyl chain 36 and 38 and 40, showed characteristic increases in NAFLD compared with no NAFLD in only non-obese subjects. The sphingomyelin levels markedly increased along with the severity of steatosis and lobular inflammation in a grade-dependent manners, especially in non-obese subjects. The best lipid metabolite combinations were separatively selected in non-obese and obese subjects, respectively, among DHs, TAGs, and sphingomyelins to predict the histological stability of NAFLD. Distinctively altered patterns of DHG, TAG, and sphingomyelin levels, depending on the histological stability of NAFLD, were also confirmed in the validation sets. Non-obese and obese NAFLD subjects exhibit unique and different circulating lipidomic signatures, including DHGs, TAGs, and sphingomyelins. These lipid combinations may be useful biomarkers for both non-obese and obese Asian NAFLD patients. All populations also were stratified into non-obese and obese subjects and then analyzed to identify the different metabolomic profiles and bile acid concentrations between non-obese and obese NAFLD patients. A total of 18 metabolites were putatively identified, and the most significantly altered metabolite between non-obese NASH and NAFLD subjects were identified as bile acids. The concentrations of unconjugated and glycotower-conjugated primary bile acids increased significantly in NASH versus NAFLD among non-obese subjects after adjustment for age, sex, insulin resistance, and PNPLA3 genotype. There was also a positive correlation between conjugated primary bile acid and histological stability in both obese and non-obese subjects, except in the case of lobular inflammation in obese subjects. And the correlation was relatively weaker in obese subjects compared to non-obese subjects. The significant increase in glycotower-conjugated primary bile acids in non-obese NASH patients compared to non-obese NAFLD patients observed in the discovery cohort was also replicated in the validation cohorts. The correlations between serum bile acid concentrations and liver histology in the validation cohort was also showed a pattern similar to those in the discovery cohorts. Targeted bile acid analysis demonstrated that glycotower-conjugated primary bile acids were commonly increased in non-obese and obese NASH, while unconjugated primary bile acids increased only in non-obese NASH. Bile acid metabolism is dysregulated with worsening the histological stability of NAFLD, independent of obesity and diabetes status. Dysregulation is more prominent in non-obese NAFLD patients than in obese patients. Finally, I would like to present gut microbiome and stool metabolized results in obese and non-obese NAFLD patients. We collected 202 stool samples from Korean Brahmin NAFLD cohorts, then we analyzed stool metabolites. We also extracted bacterial DNA from stool samples and conducted 16S rRNA amplicon sequencing for taxonomic profiling. We also performed whole genomic shotgun sequencing for metagenome functional profiling. Microbiome community changes according to fibrosis severity are different in non-obese and obese NAFLD subjects. Only in non-obese subjects, bacterial alpha and beta diversities were decreased in significant fibrosis compared to no to mild fibrosis. But there was no significant difference in alpha and beta diversity among various histological subgroups in obese or total population. In taxonomic analysis, the relative abundance of Laminococcaceae was decreased along with increasing fibrosis severity in non-obese subjects, whereas the relative abundance of Veillonella-Ceae and Enterobacteriaceae were increased along with increasing fibrosis severity in non-obese subjects. These findings suggest that Laminococcaceae may be a protective microbiome and Veillonella-Ceae and Enterobacteriaceae may be pathogenic microbiome in NAFLD. Even in multivariate analysis after adjusted for age, sex, BMI, and diabetes, such alterations of fibrosis-related microbiota were also more prominent in non-obese NAFLD subjects. Next, we analyzed bile acids and certain fatty acids in obese and non-obese NAFLD subjects. Non-obese and obese NAFLD subjects have different stool metabolites levels according to fibrosis severity. In particular, the level of unconjugated bile acids noticeably increased in non-obese subjects, along with increasing fibrosis severity. On the other hand, stool propionate levels gradually increased as fibrosis became more severe in non-obese subjects. The combination of those bacteria such as Veillonella-Ceae and Laminococcaceae and stool metabolites such as cholic acid, canodeoxycholic acid, UDCA, and propionate showed a better diagnostic performance to predict significant fibrosis in non-obese NAFLD subjects compared with people. The diagnostic ARC was approximately 0.94, suggesting the highly accurate diagnostic value. Here are my key takeaways. First, different predictors of NASH and fibrosis in non-obese and obese NAFLD subjects are visceral obesity and BMI respectively. The second, genetic risk variants such as PNPLA3 and TM6F2 independently predict the risk of NASH and significant fibrosis in Asian NAFLD patients. And a novel polygenic risk score, such as NASH PT score, as shown in our study, better predicts NASH than HAIR or NASH scores in Asian NAFLD patients. Fourth, saturated sphingomyelin levels are significantly associated with visceral adiposity and histological severity of non-obese NASH. Fifth, circulating lipidomic signatures, such as glycerolipids and sphingomyelin and bile-like species, significantly predict NASH regardless of obesity and diabetes. Finally, the diagnostic and therapeutic implications of the microbiome metabolite combinations as non-invasive biomarkers for diagnosing significant fibrosis in non-obese NAFLD may be promising finding. I thank my collaborators and funders for their commitment to my work, and I'm happy to take any questions and comments. Thank you for your attention.
Thank you, Professor Kim. Thank you for excellent your presentation. We'll have a Q&A time in discussion time. Okay, that is very interesting to you studied the prediction model, find out the high risk lean NAFLD group. Yes, that was very interesting point. Yes, next, Professor Grace Wong, would you introduce next speaker and presentation? Professor Wong, please.
Sure. Thank you, Professor Cho. I would like to once again thank Professor Kim for the wonderful talks. So please feel free to add any questions in the Q&A box at the bottom of the Zoom. We will discuss it at the end of this forum. So it gives me greatest honor and pleasure to introduce our next speaker, Professor Manu Abdulmalik. She's the world-renowned expert in NAFLD. In fact, just a few days ago, I attended her debrief in the ASLD to summarize all the updated findings of NAFLD. It's a wonderful talk. So I'm so glad that this very early morning of her time, she is so kind to join this APASL webinar. So Professor Abdulmalik is the Professor of Medicine of the Department of Medicine, Duke University School of Medicine. So her talk this morning of her time will be best practice advice for obese NAFLD. So Professor Abdulmalik, please.
And I thank the program organizers for the opportunity to speak on best practice advice for obese NAFLD. The learning objectives for today's talk are to review the best practice for treatment of NAFLD in obese subjects. We'll cover diet, exercise, the importance of weight loss, the importance of management of medical comorbidities, as well as the role of bariatric surgery and endoscopy. I think this cartoon depicts the current management of the obese NAFLD patient, where primary care physicians and specialists are working very hard but not working in unison. The pin that glues us together such that we can have forward momentum and efficacy in caring for our patients at times is missing. The treatment of the obese NAFLD patient requires an integrative approach, a multidisciplinary team of patients where the patient is at the center of care. This can include a hepatologist, an endocrinologist, a nutritionist, or other specialists such as behavioral psychologists or physical therapists. Cardiovascular risk reduction is essential as our patients are at very high risk for morbidity and mortality, and management of cardiovascular risk, dyslipidemia, diabetes, hypertension, smoking cessation has to be integral to the care of the obese patient with NAFLD. We, of course, need to screen and treat comorbid conditions that perpetuate both NAFLD and obesity, such as sleep apnea, There has been success with very integrative weight loss centers for which there are specialists who can manage pharmacotherapy, endoscopic or bariatric surgery, and guide a patient in the risks, benefits, and alternatives to such interventions accordingly. Individualized pharmacotherapy for diabetes is important as optimal glycemic control has been demonstrated to potentially alter the natural history of NAFLD, as impaired glycemic control has been independently associated with fibrosis progression. And lastly, prevention strategies for those patients with advanced hepatic fibrosis such that they receive routine screening and surveillance for complications of cirrhosis such as varices or hepatocellular carcinoma and undergo vaccination. We've come to recognize that non-alcoholic fatty liver disease is dynamic and modifiable. Certainly those patients who have stage 2 fibrosis or higher are at increased risk for disease progression to cirrhosis and its associated clinical outcomes of portal hypertension, hepatic decompensation, diminished liver synthetic function, or liver cancer. Lifestyle modification is a must for all patients irrespective of where they are in their disease spectrum and has specific implications for those patients who are obese. We understand that there are genetic and epigenetic modifiers, environmental risk factors, as well as alterations in physical activity and diet. But those patients who have advanced disease certainly may be more appropriate for targeted pharmacotherapy, but ultimately the treatment of obesity and its associated comorbidities can modify the natural history of disease. In caring for the obese patient with NAFLD also necessitates care for their comorbidities such as diabetes, defining other risk factors which contribute to not only NAFLD but their obesity, as well as confirming the absence of secondary causes of fatty liver disease. After making the diagnosis of non-alcoholic fatty liver disease, the next most important step is risk stratification. Patients who are low risk for advanced hepatic fibrosis with a low NAFLD fibrosis score, FIB4, or low transient elastography of under 8, can confidently and comfortably undergo lifestyle intervention and in fact be followed in primary care. Those patients who have intermediate or are at high risk for advanced hepatic fibrosis with a NAFLD fibrosis score of greater than 0.67, a FIB4 score of greater than 3.25, or who have a FibroScan stiffness score of greater than 9.6, or an ELF score at baseline greater than 10 or 11, may have underlying advanced hepatic fibrosis or cirrhosis, and best practice would to ensure that we identify this and survey accordingly for hepatocellular carcinoma, screen for esophageal varices if a patient meets the Bovino criteria, and monitor routinely for liver synthetic function, and also vaccinate for hepatitis A and B if antibodies are not present. Our guidelines all suggest lifestyle modification including dietary change, weight loss, and structured, and I emphasize structured, exercise interventions. Diets should achieve a reduction in calories of approximately 500 to 1,000 kilocalories per day to induce a weight loss of 500 to 1,000 grams per week. Prospective studies evaluating specific macronutrient diets are somewhat limited. However, recent data suggests that either low fat, low calorie, or even a Mediterranean diet can improve NAFLD. It is imperative that patients exclude NAFLD promoting components in the diet, specifically processed foods and added fructose in the form of sweetened beverages. Higher thresholds of weight loss, particularly in obese patients, can improve necroinflammation and fibrosis. And exercise alone can improve hepatic steatosis, but the effect of exercise on other histologic endpoints, specifically advanced hepatic fibrosis, are unknown. And both exercise in the form of aerobic or resistance training reduce liver fat, reduce weight, and therefore we should tailor these interventions appropriately to our patient's preference and their ability to sustain them long term. Bariatric surgery can reduce fatty liver and the histologic features of NAFLD, NASH, and fibrosis, but should be individualized, particularly in those patients who have cirrhosis. Our current practice guidelines do reserve pharmacotherapies for patients with biopsy-proven NASH and fibrosis. The APASL guidelines explicitly state that patients without steatohepatitis or fibrosis should receive counseling and healthy diet with no pharmacotherapy for their liver disease. For those patients who are obese with NAFLD, treatment of obesity is the foundation of care. A 5% reduction in BMI translates into a 25% relative reduction in liver fat by MRI-PDFF, and a systematic review of 23 studies reveals that weight reduction of 4 to 10% consistently improves measures of liver fat and serum transaminase levels. Across nearly all studies included in this meta-analysis, weight loss improves liver aminotransferases. Furthermore, in this meta-analysis, weight loss consistently improved hepatic steatosis. Weight loss through lifestyle modification improves NASH for obese subjects, and in fact, the higher the threshold of weight loss, the higher the probability of NASH resolution and fibrosis regression, with 45% of patients who achieved more than a 10% weight loss having an improvement in fibrosis. The unfortunate reality is less than 10% of subjects could sustain this weight loss long term, despite having gone through an intensive lifestyle intervention. This speaks to the fact that we must really strive to develop systematic programs that facilitate not only initial weight loss, but the ability for our patients to sustain weight loss long term, such that the impact on their end organ injury and resolution of NASH and fibrosis regression can also be sustained. There is evidence in animal models that routine exercise retards hepatocarcinogenesis, and in fact, the obese diabetic phosphos mouse, which is an animal model for NAFLD and NASH, when compared to the lean wild-type mouse, when subjected to a carcinogen, develops hepatocellular carcinoma. However, when these animals were routinely exercised, not only did the risk of liver cancer decrease, but tumor burden and as well as the number of foci of liver cancer decreased. This was associated with weight loss as well as improvement in insulin resistance. And in fact, there is evidence in humans that vigorous physical activity at least 5 days per week and 415 subjects decrease the risk of hepatocellular carcinoma by 44%. A recent study in 50 patients with compensated cirrhosis who had increased hepatic vein pressure gradients, 72% of which had clinically significant portal hypertension with a hepatic venous pressure gradient of greater than 10 millimeters of mercury, who were overweight or obese, underwent a 16-week intensive lifestyle intervention. And as you could see, despite the presence of cirrhosis, 52% of patients were able to achieve greater than 5% reduction in body weight. And this did correlate with an improvement in portal pressure. In fact, nearly a 10% drop. The higher the weight loss, those patients who achieved more than 10% reduction in body weight had nearly a 25% reduction in portal pressure. I'd like to transition a little bit into the role of anti-obesity approaches, specifically FDA-approved anti-obesity drugs, touch a little bit on bariatric surgery and bariatric endoscopy in the management of the obese patient with NAFLD. There have been several therapies approved by the FDA since the late 1950s for the treatment of obesity. 3 of those therapies have been studied in patients with NAFLD and NASH, that is orlistat, liraglutide, and semaglutide. Common side effects of anti-obesity drugs include dry mouth, insomnia, nervousness, increased heart rate or palpitations, fatigue, or gastrointestinal side effects. There is risk for drug-drug interactions given the polypharmacy that we see in patients with obesity and diabetes. Furthermore, the placebo-subtracted weight loss varies between 3 to 10% and is really not substantially different than the weight loss that can be achieved in the majority of patients with lifestyle intervention. There is limited data on anti-obesity drugs on the histologic outcomes of NAFLD and NASH. Orlistat decreases liver fat as measured by MR-PDFF in a parallel group open-label 24-week randomized trial of 170 patients with obesity and NAFLD. Orlistat improved the severity of liver fat by MRI-PDFF compared to routine treatment. A representative MRI is noted in the right upper hand side of this slide, where you could see a liver fat reduction from 29% to as low as 8%, and this was statistically significant compared to standard treatment. However, another study by Steve Harrison demonstrated in 50 obese patients with biopsy-proven NASH who received either diet and vitamin E with or without orlistat for 36 weeks, that it wasn't, in fact, the orlistat or the dietary intervention, but the ability for the patients to lose weight that in fact correlated with an improvement in histology, irrespective of what treatment they were randomized to. What about the role of GLP-1 receptor agonists? This is a highly pleiotropic class of compounds that decreases appetite, improves satiety, optimizes the cardiometabolic health, and decreases lipolysis and hepatic glucose production while improving pancreatic insulin secretion. Just to draw to your attention the weight loss effect of GLP-1 receptor agonists in patients with diabetes who were studied in 3 large registration trials, SUSTAIN 3, SUSTAIN 7, and SUSTAIN 10, semaglutide was compared to exenatide, dulaglutide, and even liraglutide, and as you could see, the change in weight loss was more significant with semaglutide in all these studies. Liraglutide versus placebo in a paired liver biopsy pilot study, studying 1.8 milligrams subcutaneously daily, did meet the endpoint of NASH resolution without worsening of fibrosis and was associated with a change in weight and a change in ALT. Semaglutide has also been studied in a double-blind randomized phase 3 trial in adults with obesity or overweight status with comorbidities and no diabetes. And all the subjects received standard lifestyle interventions, 17 counseling sessions, a hypocaloric diet, and increased physical activity versus semaglutide escalated to 2.4 milligrams weekly for 68 weeks. And as you could see, a dramatic weight loss effect of nearly 15% with semaglutide. And the majority of patients, 86%, were able to lose 5% or more of their weight loss, and approximately 32% lost 20% or more weight loss. In a recent study published by Phil Newsom, a 72-week phase 2 trial of 320 patients with biopsy-proven NASH fibrosis stage 1 to 3, semaglutide at every dose studied, 0.1, 0.2, and 0.4 milligrams, achieved the endpoint of resolution of NASH without worsening of fibrosis. And so while NASH resolution endpoint was met, it did not achieve the primary endpoint of fibrosis regression. The safety of GLP-1 receptor agonists in patients with NASH is consistent with that has been observed in other trials, and is most commonly observed side effect with either semaglutide or liraglutide or gastrointestinal symptoms. As you can see here in this slide, there is a dose-dependent decrease in body weight as well as an improvement in glycemic control. And in this study, while it failed to achieve the primary endpoint of improvement of 1 point in fibrosis stage, the use of semaglutide compared to placebo did suggest that fewer patients had worsening of fibrosis on the higher dose of semaglutide, 4.9% compared to 18.8% on placebo. NASH resolution has been reported with bariatric surgery, and certainly bariatric surgery is an effective intervention for the treatment of obesity and its complications. It improves lipids, weight, normalizes liver aminotransferases, and cures type 2 diabetes in the majority of patients. It also results in NASH resolution in patients who are can effectively lose more than 10 kilograms of weight in about 90% of subjects. Fibrosis resolution has been reported with bariatric surgery. Over a 5-year period of follow-up, there was downgrading from the baseline liver biopsy in fibrosis stage, with 63% of patients who had baseline mild hepatic fibrosis completely resolving fibrosis at 5 years, and 45% of patients with more advanced hepatic fibrosis having resolution of fibrosis. There were only 5 patients in this study that had cirrhosis, and as you can see, very little movement in cirrhosis despite 5 years of follow-up. Endoscopic and metabolic bariatric therapies have been evaluated for obesity, and outcomes of associated NAFLD and NASH have been reported. These tend to be small studies. Gastric, endoscopic, and metabolic bariatric therapies show weight loss dependent improvements in liver biochemistry and histologic features of NAFLD and NASH. These include the aspiration therapy, endoscopic sleeve gastroplasty, or even the gastric balloon. Small intestinal endoscopic and metabolic bariatric therapies have been reported in pilot studies, but shown to improve insulin resistance and weight loss in both dependent and independent pathways such as incretins or alterations in gut microbiota. These include the endobarrier device, mucosal ablation, or incisionless anastomotic systems. Irrespective, we do need larger randomized controlled trials to assess and define safety and efficacy in patients with obese NAFLD. So in summary, to make a long story short, treating obesity is the foundation of management for NAFLD and NASH and requires a multidisciplinary team. Anti-obesity pharmacologic therapy may be integral to the treatment of obese patients with NAFLD and NASH in clinical practice, but warrant further investigation if used specifically for the indication of NASH. Bariatric surgery improves NASH and hepatic fibrosis and is highly effective in treating obesity and the associated metabolic complications. But treating obesity can ultimately decrease the risk of progression to cirrhosis, liver cancer, and portal hypertension. Thank you very much for your attention.
Thank you so much, Professor Abdulmalik, for the wonderful lectures. So once again, I would like to invite the delegates to put down your questions in the Q&A box, and then at the end we will discuss together. So now I have a very great honor and pleasure to introduce the next speaker, Professor Atsushi Nakajima. He's the professor from the Department of Gastroenterology and Hepatology, Yokohama City University. Professor Nakajima is a very active researcher, clinician scientist in the field of hepatology, and he has a lot of international collaboration and publication. And this evening, he's going to share with us an important topic about the best practice advice for non-obese lean NAFLD. So, Professor Nakajima, please.
Thank you, Grace. Thank you, organizing committee, to give me a chance to present here. If my internet condition is okay, so can you see my slide?
Yes, very clear. Thank you.
Okay. So this is my COI. So the first, the definition of non-obese NAFLD and the lean NAFLD is very important. Sometimes or often misunderstanding. So as you can see here, non-obese NAFLD for Asian is less than 25 BMI, and the Caucasian less than 30. And lean NAFLD is defined for Asian less than 23 BMI, and the Caucasian less than 25. This is very important, sometimes confusing. So the first, the epidemiology of non-obese and lean NAFLD. As you can see here, overall around 40% of global NAFLD population was classified as non-obese. And you know, among people with non-obese or lean NAFLD, 39% had a NASH, 29.2% has a significant fibrosis, and 3.2% had a cirrhosis. This is reported in the recent Lancet Gastroenterology Hepatology. You know, the 40% is unexpectedly high. So this slide shows the global prevalence of non-obese NAFLD in the NAFLD population. As you can see here, in Sweden and Austria, about 70% non-obese among NAFLD population. On the contrary, Malaysia 12.9%, and Pakistan in 22.5%. And overview of the Asian countries, around 30 or 40% is a non-obese patient among NAFLD population. The pathogenic mechanism underlying the development of non-obese NAFLD is also presented by the Professor Kim, but I mentioned based on the several papers, higher cholesterol and lower polyunsaturated fatty acid intake than did obese individual with NAFLD is mentioned, and especially high fat intake and especially fructose is one of the risk factor for the non-obese or lean NAFLD. And the other pathogenesis underlying the development of non-obese NAFLD is the gut microbiota, also presented by the Professor Kim. He present decreased in desulfobibulonase was associated with NAFLD in the lean NAFLD group. And the other paper from Brazil demonstrates the NASH has a specific gut microbiota, lower abundance of Faecalibacterium plautinits and Luminococcus. But the number of patients is just only 4. So these studies have not shown a consistent composition of gut microbiota, possibly because of the environmental factors and the genetic factors, such as diet, region, country, and race. And recently, our group published the gut microbiota associated metabolite in a patient of non-obese NAFLD. In a cohort of Japanese non-obese NAFLD, the U bacterium is significantly lower than that of the obese and healthy control. And in a fecal metabolite, butyric acid is significantly lower than the obese control ones. Considering that the short chain fatty acid, including butyric acid, suppress the inflammatory reaction in gut mucosa or liver. So this observation is very important in addition to the gut microbiota. The last thing I have to mention about the pathogenesis for the development of NAFLD, non-obese NAFLD is also mentioned by the Professor Kim, the PNPL3. So this is my previous paper demonstrating that GG genotype, the obese NAFLD, is found in my cohort, non-obese cohort. So next, we move to the diagnostic performance using the several NITs. This is a paper by Professor Vincent Wann's group, and they compared a non-invasive assessment diagnostic accuracy between obese and non-obese NAFLD patient. As you can see here, liver stiffness measurement, Fibro index and the NAFLD fibro score, the Apri-Bird score, and the AST to LT ratio are useful tests to detect advanced fibrosis in obese as well as non-obese patient, suggesting a major NITs can be used for non-obese patient with NAFLD. Until recently, non-obese NAFLD has been considered a benign condition. As you can see here, these meta-analyses demonstrate the histological severity in lean versus overweight obese NAFLD tell us benign overweight obese can raise the risk of NASH by 1.7-fold. This image illustrates the result yielded by the meta-analysis of histological feature of NAFLD in lean and overweight obese patient. Relative to lean NAFLD, overweight obese NAFLD patient tend to show a modest increase in the score of histological outcome associated with disease severity, including liver fibers. As you can see here, in lean or non-obese one, as weight getting gained, so the steatosis score activity, the fibrosis are getting worse. But the recent paper from Sweden demonstrating that the lean NAFLD are at a higher risk of development of severe liver disease. This is a paper from Swedish group published in Hepatology Communications 2018. During a mean follow-up about 20 years, representing 12,631 person years, patient with lean NAFLD has no increased risk of overall mortality, as you can see left panel, but an increased risk of development of severe liver disease was found. The hazard ratio is 2.69. This is a control, and this is non-obese, and obese and lean. So finally, recent meta-analysis for non-obese and lean NAFLD published in the Lancet Gastroenterology last year, showing that the incidence of all cause of mortality for non-obese individuals with NAF was 12.1 per 1,000 person years. liver-related mortality was higher in non-obese NAFLD population than in the obese NAFLD. So a non-obese NAFLD patient have a better prognosis or not. My comment is still controversial. Different ethnic group or location might lead the difference of the result. We need more evidence, especially from the Asian countries. Different observation period may provide a different result. Further study are required. So the treatment, tips for the lifestyle modification. The basis of treatment is to improve the risk of factors that contribute to non-obesity. The first, limit intake of fructose and fat. Effort to bring the patient back to his or her weightage at 20. Effort to reduce visceral fat. The target body weight reduction is from 3 to 5%. Finally, calorie restriction must be done carefully because it induces the sarcopenia. So this is a paper from Professor Vincent Wan in 2018, the Journal of Hepatology. This is a very, very excellent paper showing the beneficial effect of lifestyle modification for the non-obese patient with NAFLD. So as you can see here, patient randomly assigned to the intervention group underwent a lifestyle modification program with a dietitian or exercise trainer for 1 year. This program focused on increasing energy expenditure and decreasing calorie intake. This is the result. As you can see here, half of non-obese patients achieve the remission of NAFLD defined as intrahepatic triglyceride content less than 5% by MRI PDFF. But as you can see here, the obese one achieves 50% of NAFLD remission at body weight reduction 7 to 10%. So tips for the exercise is also there is still insufficient evidence for exercise therapy specific to non-obese or lean. The following 3 points may be important. This is my opinion. So understand the exercise therapy can improve NAFLD in non-obese patients. Since cardiovascular events are common even in non-obese individuals, it is important to incorporate aerobic exercise. Non-obese NAFLD patients often have sarcopenia, so resistance training should be used to increase muscle mass. Furthermore, exercise therapy is more important for non-obese patients because reducing diet may further aggravate sarcopenia. It is reported that the presence of the PNPL3 risk guide was associated with a better response. Risk leads a better response to lifestyle modification. It is important tips for the hepatologist to take care of the non-obese patient. So this is a paper from just published Journal of Hepatology in Japanese recommendation for the lifestyle modification. In this paper, non-obese one is recommended. Target body weight reduction is 3 to 5%, which is based result from the Vincent Wan's paper. The last my topic is pharmacological approaches. The basis of drug treatment to ensure that the complications such as hypertension, dyslipidemia, and diabetes are treated. Weight loss is of limited utility and may prove harmful in non-obese. Although there is no specific evidence drugs that cause weight loss should be used with caution because of the risk of sarcopenia. There are currently limited options in terms of pharmacological agent. However, there is some evidence for the use of pyrrolidazone and vitamin E in the treatment of diabetic and non-diabetic patients with biopsy-proven NASH, including non-obese one. So the treatment strategy is wrap up here. The one is exercise dietary therapy, resistance training, and aerobic exercise are recommended. Target weight loss is 3 to 5%. Dietary restriction may increase the risk of sarcopenia. So the main goal should be that to improve the diet rather than decrease the food intakes. Especially to be more specific, take olive oil rather than animal fat. Avoid eggs and the fish eggs, salmon roe, cod roe, sea urchin, caviar, which contains high cholesterol. Avoid too much fruits and the soft drink, which contains a lot of fructose. Eat more fiber, which produce the short-chain fatty acid by gut microbiota. The pharmacological therapy is pioglitazone for diabetes mellitus, ARB, ACI for the hypertension, statin, and the pemafibrate. This is only approved in Japan for the dyslipidemia, but the recent paper by ours demonstrate that pemafibrate improves the liver function and improves the liver stiffness measured by the MRE. And the last one is drug that cause weight loss should be avoided. This is an acknowledgement of our collaborator that he is Professor Richard Eman, Professor of Radiology in the Mayo Clinic, who is an inventor of the MR elastography. And he is Rohit Rumba, my favorite collaborator. And they are my lovely collaborator from the Go Asia Consortium from the 11 countries from Asia. And he's WK and Dan from Singapore, and he's a great guy, Vincent Wan. And we thank for the Japanese study group of NAFLD. Thank you for your attention.
Thank you very much, Professor. As mentioned, there is a Q&A box on the right side of the screen. So if you have any questions, this will be addressed at the end of the panel. So non-alcoholic fatty liver disease is one of the fastest emerging manifestations of metabolic syndrome. And although a steady progress is seen in the understanding of the disease, epidemiology, pathogenesis, and identifying therapeutic targets, the slowest advancement is seen in the therapeutic field. It would be interesting to understand the novel and upcoming therapeutic options in non-alcoholic fatty liver disease. And this will be discussed by Dr. Stephen Harrison. Professor Harrison is a visiting professor of hepatology at the Radcliffe Department of Medicine, University of Oxford. Professor Harrison currently serves as the medical director for the Pinnacle Clinical Research and the president of the Summit Clinical Research in San Antonio, Texas. To give us a lecture on understanding the novel and upcoming therapeutic options in non-alcoholic fatty liver disease is Professor Stephen Harrison. Professor?
Yeah, thank you, Diana. Can you hear me okay?
Yes, Professor, perfect.
Perfect. Well, thank you so much for this wonderful opportunity to present novel and upcoming therapeutic options in NAFLD to you guys. We just wrapped up AASLD here in the United States and had the opportunity to give a similar lecture there. So it's my honor to present kind of where we are with the state of the art for you guys as well. So these are my disclosures. So drug development in fatty liver disease has really focused around what the FDA is requiring to reach conditional approval of a drug so that it can be marketed and sold in the US particularly, and then hopefully then throughout the world. It currently relies on a histopathologic endpoint of NASH resolution or fibrosis improvement, or the combination of both. The definitions of NASH resolution you see here, that simply means that you have to have no ballooning on histopathology at the end of treatment, and inflammation has to be 0 or 1. There is no credence given to steatosis as part of NASH resolution. For fibrosis improvement, you need at least a 1-stage improvement in fibrosis by our ordinal semi-quantitative scale, with no worsening of steatohepatitis. Now, you might ask, why is that the case? Why does the FDA mandate histopathologic resolution of NASH or fibrosis improvement? And that's because it takes a long time to reach a clinical outcome in patients with fatty liver disease. So by looking at a surrogate of an outcome, we're able to reach drug approval years in advance. Now, it's important to understand where the FDA reached this conclusion. There have been multiple meta-analyses that have been done looking at fibrosis stage and progression to outcomes, whether it's severe liver disease or liver-related mortality. Here is 2 examples looking at where F3 and F4 are linked to hazard ratios that are significantly elevated as in regards to severity of liver disease. And on the right, you see on the vertical axis mortality rate ratio, and that is connected with F2 or greater liver disease. Furthermore, recent data that is now online ready in hepatology has shown that improvement of fibrosis by at least 1 stage is linked to improvement in outcome. And we see this illustrated here from the STELLAR-4 and simtuzumab data, where a 1-point improvement in fibrosis stage is linked to improvement in liver-related events, as shown on the x-axis. Now, Manal Abdulmalik showed a little bit of this in her presentation as well, looking at bariatric surgery. And here, what you see in the pie chart is pre-surgery. The majority of the pie is blue or dark gray or light gray, which represents NASH with mild, moderate, or severe inflammation. As you go post-surgery from 1 year to 5 year, what you see is the gray part of the pie growing substantially, which is no NASH. And ultimately, we see that NASH resolution with no worsening of fibrosis occurs in 84% of patients 5 years post-surgery. And this is associated with a 70% improvement in fibrosis over the same time period. So as we move away from fibrosis improvement, we can ask the question, is NASH reversible? And if it is reversible, is it linked to fibrosis improvement? And we see here from the same paper that the answer is yes. As you lose more and more weight, as illustrated in the bar graphs that are blue and orange, you have more and more resolution of NASH. On the right-hand bars that are red in color, you see that as you go from baseline to 5 year, less and less fibrosis is evident. And so NASH improvement is correlated with weight loss and is linked to fibrosis benefit. Additional supportive data comes from Dave Kleiner, a pathologist at the NIH, who published this work along with his colleagues in JAMA. Here, what we see on the left is that as you improve the NAFLD activity score, you improve fibrosis stage. Illustrated on the right is 2 columns, one showing the first biopsy, which has NASH. The second column is the last biopsy, which shows no NASH. And you can see that the fibrosis stage over time diminishes, and the percentage of patients with F0 or F1 disease rises significantly as you resolve NASH. Additional data shown from the Golden 505 study, which is a phase 2b study with elafibranor, which is a PPAR alpha delta agonist, you see the same thing. Here on the left are blue and gray bars. The blue bars represent fibrosis improvers. The gray bars represent fibrosis worsening. And on the y-axis, or the horizontal axis, we see the change in activity index. As you improve ballooning and inflammation, you improve fibrosis. This is also illustrated on the right. We can focus, but let's not lose sight of the full picture. It's not just about the liver. These patients also have significant extrahepatic manifestations of disease that should be considered in the management along with the underlying histopathology. So while we focus on NASH resolution and fibrosis improvement, it's important to not forget the lipotoxic fat, weight loss, atherogenic lipid improvement, and glycemic control. By considering these additional attributes of a drug, we can see that this likely will lead to improvement in adverse liver-related outcomes, as well as major adverse cardiac events and reduction in overall mortality. So the next question is single therapy enough, or will this require combination therapy? Well, just a quick slide to show potential therapeutic targets that are currently in development. We know that the majority of fat that comes into the liver is through peripheral adipocyte dysfunction, which leads to free fatty acid flux into the liver. So by modulating or blocking that, we should ultimately improve underlying fatty liver disease. We can modulate lipogenesis within the liver through blocking de novo lipogenesis through FASN inhibition or acetyl-CoA carboxylase inhibition. We can work specifically on mitochondria to improve dysfunction. We can work on the inflammasome through Kupffer cell modulation. We can modulate stellate cell activity directly. And additional work is now being done through precision medicine techniques to modulate genetic influences as well as the microbiome. So when we think about targeting pathophysiological processes, I put them into 5 different buckets. Among these, we see that the majority of drugs in development are targeting insulin resistance and/or lipid metabolism and targets related to lipotoxicity and oxidative stress. Some of these drugs are pleiotropic and attack multiple different buckets you see listed here. The drugs in red are those currently in phase 3 development in the United States. I use this slide to illustrate the phase 2 drugs in development. The drugs on the left are drugs that are in early phase development and have non-invasive endpoints. Excuse me, the drugs on the right are those in phase 2b that have histological endpoints. The arrows signify those studies that have completed enrollment or have read out already. The boxed green drugs are compounds that are still enrolling, and you see the asterisks by NGM, which is an FGF19 analog, and BMS, pegbalfermin, which is an FGF21 agonist. Both of those data sets were recently presented at AASLD. Moving on to those phase 2 agents and their route of administration. The agents on the left are all oral, and you see a large number of them in development currently. But we also have a significant number of injectable or infusion agents on the right. This will become important when we begin to think about combination therapies of injectables and or oral agents. What about phase 3 agents? We see 5 of them currently in development, 4 of which are oral, 1 injectable. There is one drug that has completed its subpart H approvable endpoint. That's obeticholic acid. It has filed its new drug application with the FDA and unfortunately did not reach approval. This hasn't thwarted their efforts to potentially refile, and they're working on that now. Lanifibranor and semaglutide, as well as resmetirom are currently enrolling phase 3. Aramcol is currently on hold. I wanted to show very quickly the results of a very stringent endpoint, and these are for drugs in phase 2 development. You see in the boxes, efruxifermin, aldafermin, and seladelpar. And you see that when you use a combined endpoint of both NASH resolution and fibrosis improvement, the placebo group tends to minimize, and we see that across the board. It's a little bit harder to hit this endpoint, but we see that as a general rule, you see a better dose response relationship, and as it relates to placebo, a better delta. These are the drugs that have moved on to phase 3, lanifibranor and semaglutide, and very similarly, we see placebo responses that top out around 15%, and the high dose arms having efficacy of around 35 to 37%. There's also several drugs in NASH cirrhosis development. We see those listed here. Some are actively recruiting and some are not, but I do think this is a very target-rich population to see if we can improve underlying liver disease in this heretofore yet untreated population. So the future looks promising. Here is just a list of drugs in phase 3 currently, and when we anticipate the FDA readouts, we see that Aramcol is on hold. Resmetirom looks to complete their Subpart H approval next summer. Beta-cholic acid is anticipating to refile sometime in 2022, and we see semaglutide and lanifibranor currently enrolling. As we put all this together, I wanted to illustrate my perspective, where I combine both histopathologic and extrahepatic profiles of agents. I think it's important that drugs to treat our patients target both, not just histology, but also the extrahepatic benefits. I broke this into non-cirrhotic NASH and cirrhotic NASH as illustrated on the 2 different bar graphs. The ideal therapy would be in the upper right-hand part of these bar graphs, or these graphs. So I'm just using an illustration here. Efruxifermin on the left for non-cirrhotic NASH looks like it has pretty decent histopathologic impact as well as benefits extrahepatically. The same can be said for semaglutide. When we also look at the adverse event profile, this is critical as well, because patients are generally asymptomatic and they will likely need to take therapy for a prolonged period of time. So the better the therapy is tolerated, the more likely they'll take it for a long time. So those in mild get a blue bar or blue box. Those in gray are mild to moderate and have more side effects. So it's important to understand that as well. On the right is cirrhotic NASH, and interestingly, there's only 2 drugs that have read out histopathology as it relates to cirrhosis, and efruxifermin appears to have some benefit histopathologically, albeit as a very small set of data, and further studies are underway to validate that efficacy. Belapectin is made by a company called Galectin Therapeutics. It's an infusion therapy. It's incredibly well tolerated, and its readout did not show a histopathologic benefit. However, it did have a subset of patients that appeared to reduce the rate of progression to varices, and they're underway now enrolling an adaptive phase 2b/3 study. So just to summarize, the first drugs in development are at the very early stages as correlated to the biplane you see on the left. What we'd like to get to is the 5th generation strike fighter on the right. We have lots of work to do to get there, and ideally we'll use combination therapies and precision medicine techniques to help us get there. Here's just a quick overview of combination therapy as it relates to severity of disease. If you have mild disease, safety and tolerability are paramount, and likely targeting the steatosis and the inflammation component would be the best way to go about this. And oral agents are in my opinion, deemed to be the best agents for this milder stages of disease. On the right, we see cirrhosis or advanced liver disease. Here, patients have a higher risk tolerance, and adverse events or the route of administration could be modulated slightly if you're able to get a bigger bang for your buck as it relates to underlying histopathology. And here I think we also need to target fibrosis more directly. So the ideal combination agent would be oral, well-tolerated and safe, synergistic on its impacts not only histopathologically, but also in extrahepatic manifestations. And we would also enhance long-term outcome benefit. As we look to the future, precision medicine is no doubt going to play a role. Here is a paper illustrating CAR T therapy. This is an animal model that was where fibrosis and cirrhosis was induced, and the patients were subjected to CAR T therapy. The idea here is that you would tag senescent stellate cells with T cells that would kill the senescent stellate cells and ultimately lead to fibrosis regression. In this elegant paper by Amor and colleagues published in Nature in 2020, we see just that happening. It's not just therapy for cancer. There is evidence that CAR T therapy could target underlying liver disease as well, particularly the fibrosis. Therapeutic oligonucleotides, such as siRNAs, could also be helpful, targeting specific microbiome components as well as genetic polymorphisms such as HSD17 beta 13, a loss of function single nucleotide polymorphism, and PNPLA3 are also underway. So in conclusion, our understanding of NASH pathogenesis as it improves, the number of targets in drug development will continue to expand. Therapies aimed at both histopathology and dysregulated metabolism are ideal. Synergistic combination approaches potentially overlaid with precision medicine advances may allow for broad application. And finally, precision medicine will impact NAFLD drug development in the not too distant future. Thank you for your attention.
Thank you. Thank you, Professor Stephen Harrison. We thank you for your excellent lecture and presentation on the recent development of new therapeutic modality and the prospects. Okay, Professor Helen Lee, are you online?
Yes, I'm here.
Yes, okay. Could you give us summarize our case and wrap up, please?
Sure. I'm back. I will briefly summarize the patient progress. For the non-obese patient with NASH, lifestyle intervention, which include dietary education and regular exercise, was prescribed. She followed this prescription well and achieved weight loss of 3.2% in 6 months. Laboratory findings were improved after weight loss. AST was decreased from 178 to 69, and ALT was normalized from 270 to 36. Gamma GT was also reduced from 109 to 93. In addition, the CAP score came down from 305 to 284 after weight loss of 3.2%. Liver stiffness values was maintained from 12.5 to 12.1 kilopascal. Hepatic steatosis index was changed from 37.5 to 28.9. However, fibrosis 4 index was maintained. We assessed that the patient had non-alcoholic steatohepatitis with BMI less than 25. She achieved modest weight loss and showed improvement in liver enzyme. She wants to participate in clinical trial, so we are considering enrolling her in an appropriate clinical trial for targeting NASH resolution and or fibrosis improvement. For the second case, obese NAFLD patients was also recommended lifestyle intervention, including calorie restriction and regular exercise. He achieved weight loss of 1.1% in a year. He is on metformin, rosuvastatin, and omega-3. There were only feeble changes in laboratory findings after a year of lifestyle intervention. AST was changed from 40 to 34, and ALT decreased slightly from 62 to 56. Gamma GT increased from 100 to 126. Triglyceride went down to 152 from 488 after medication treatment. Blood sugar was not well controlled. Hemoglobin A1C maintained high from 7.4 to 7%. Additionally, CAP score was changed from 351 to 334 after weight loss of 1.1%. Hepatic status index showed no change from 45 to 46. For diabetes and obesity control, SGLT2 inhibitor and GLP-1 receptor agonist was added for these patients. After 6 months of treatment, 5.3% of weight loss was achieved in these patients. This change was reflected in CAP score, which came down from 334 to 283. Hepatic status index also came down from 46 to 41. We assessed that the patient had non-alcoholic fatty liver disease with obesity. He is still in progress of weight loss. Controlling of combined metabolic disease in this patient is one of the key treatment managements. For him, treatment of obesity and diabetes is associated with the improvement of hepatic statuses. To recap, we reviewed 2 cases today. One patient with lean NASH and the other with obese NAFLD. Lean patients with NASH achieved modest weight loss and improved hepatic statuses, which was evaluated by non-invasive tests. We are further considering clinical trials for targeting NASH resolution and or fibrosis improvement. For the second case, despite hard times to lose his weight in obese NAFLD patients, weight loss and disease control of combined metabolic disease finally improved his hepatic statuses, which was evaluated by non-invasive tests. Thank you again for your attention.
Thank you, Professor Lee, and all speakers for a nice presentation. Finally, we have a discussion time. Please feel free to ask a question and discuss. Professor Chris Wang, read the question time, please.
Okay, thank you, Professor Cho. We received quite a handful of questions in the Q&A box. So, in fact, the first questions asked about were IgA and ferritin level checked in both cases. So, would Professor Hee-Won Lee like to address this issue, IgA and ferritin?
Thank you for the good question. Actually, we did not check IgA in both cases, but we checked the ferritin. So in lean NAFLD case, I do not remember the exact level, but ferritin was slightly elevated around 400. In the second case, in obese patient, he has a normal ferritin level. So we did not check any IgA level for both cases.
Oh, I see. Thank you. Another delegate would like to know about the thyroid function. So was thyroid function also checked in your patients?
Yeah, we did it. So both patients had normal thyroid function.
Oh,
Thank
so
you.
nice. Yeah, so you have, in fact, very extensively evaluated your patients. That's so nice.
Yeah, we excluded thyroid and autoimmune disease as well. Mm-hmm.
Okay, thanks a lot. Okay, so there is another questions related to something about alcohol. We know that NAFLD some quite often may overlap with alcoholic liver disease. So there's a question from Dr. Jayanthi asked about, is there a greater risk for HCC in NAFLD related advanced fibrosis or cirrhosis? are compared to alcohol-related cirrhosis. So I think this delegate would like to compare the risk of NAFLD versus alcoholic liver disease. So would any of our speakers like to address these questions? May I invite Professor Kim, Professor Wong Kim, would you like to address these questions? In your experience, do you think that the risk of HCC in NAFLD patients in the presence of advanced fibrosis and cirrhosis, is it similar or higher or lower compared to alcoholic-related cirrhosis? Thank you.
I already answered this question in the Q&A box, but I would like to remind my answer to you again. So as usual, compared with viral hepatitis-related cirrhosis, alcohol-related cirrhosis or NAFLD-related cirrhosis can progress less frequently to HCC as compared to viral-related cirrhosis. But we do not know the exact difference in the risk of HCC development between alcohol-related cirrhosis and NAFLD-related cirrhosis, because even though they do not have any evidence of cirrhosis in patients with alcoholic liver disease or non-alcoholic fatty liver disease, they even develop HCC infrequently. So we do not assess the exact risk of alcohol-related and non-alcohol-related cirrhosis in terms of the risk of HCC developments.
I see. Thank you very much, Professor Kim. So another question is, in fact, Professor Abdul Malik has been so kind to address in the box already. But if you don't mind, because we still have some time, maybe I still bring it up so Professor Abdul Malik can further elaborate a bit more. In terms of diabetic patients that are obese, so the patients are obese, should we screen all of them for NAFLD with liver fibrosis? So would Professor Abdul Malik also advise us for the screening strategy in diabetic patients for NAFLD? Thank you.
Well, certainly there's an abundance of evidence that patients who have diabetes are at markedly increased risk for NASH and advanced hepatic fibrosis, nearly double what we would otherwise see in a non-diabetic cohort. So in my opinion, best practices would include targeting high-risk cohorts such as those with obesity and diabetes, and specifically paying attention to an assessment of liver enzymes with routine clinical care, and risk stratifying those that have 3 or more metabolic risk factors, older age, elevated liver enzymes, for the presence of advanced hepatic fibrosis, because that presence would certainly change clinical care and management long-term.
Yeah, definitely. Thank you very much. So in fact, many of our endocrinologists, they do quite extensive diabetic complication screening in diabetic patients. So will you think that, in fact, screening for liver fibrosis should be one of the part of the assessment for diabetic complications?
I think we should not only be screening for liver fibrosis, but we should be screening for NASH, because that's the strongest predictor of fibrosis progression. Wow. So while it's not really in all practice guidances yet, and those are currently being rewritten, I think high-risk cohorts warrant an assessment of liver enzymes and an abdominal ultrasound to assess for presence or absence of fatty liver.
Yeah.
Professor Stefan is online. Professor Stefan.
Yeah, hey, I'm here.
Yeah, so there is some question to you. What do you think of metformin from saline, propylsaline? What do you think of metformin in obese NASH cirrhosis? We had presented at the ASLD a few years ago that metformin reduced fibrosis and HVPG by 12 months.
Yeah, I'm familiar with Professor Sarin's work. I think it's very well done. We haven't, in the US, we haven't looked at metformin for its utility in reducing portal hypertension or cirrhosis. However, what we do know, and this is something I use in clinical practice, is we know that metformin as well as statins have been linked to regression of occurrence of hepatocellular carcinoma. So I use it as a chemopreventative in many of my patients. Why do I do that? Well, very often cirrhotic patients have diabetes and they also have hyperlipidemia. And so in the United States, metformin remains foundational for the management of diabetic patients. It's well tolerated in cirrhotics and it doesn't increase the risk of drug-induced liver injury. And we know with statins, again, I know that wasn't the question, but I think similarly, we can discuss statin use. It is well tolerated in cirrhotics. The risk of drug-induced liver injury is less than 1%. And potentially there's even more data linking statin use to reduction in portal hypertension, and Jaime Bosch has been a pioneer in leading that effort.
Thank you. Thank you. I have another question to Professor Nakajima. Nakajima is online?
Yes.
Are you online? Yes. Should we follow the NAFLD patient? If we should do, who are the high risk group to be followed up? Who are the high risk group should be followed up in lean NAFLD group?
Oh, yes. So, but you know, we have very limited evidence for the in terms of following the lean or non-obese NAFLD. But the most important thing is to measure the fibrosis stage by the FibroScan or MR elastography. That if the patient is advanced fibrosis, that is F3, F4, it is a patient who should take care.
Yes, thank you very much. Yes, another question or comment, please.
I have a question for Professor
Won
Lee. In your case 1, you showed a weight loss, but the cholesterol levels of your patient increased. Do you have a significant impact of the increased cholesterol despite the weight loss of your patient?
Thank you for your question. If I remember right, it's slightly increased, but they are within normal limits. So we do not start any statin or dyslipidemia drug. They are within normal limits.
Oh, okay. Or Professor
maybe may I ask the questions to the presenters? This is George Lau from Hong Kong. Yes, we have heard a lot of data about the Korean populations, especially with the use of EQTL and so on to predict fibrosis effect. I just wonder whether this data has been validated in non-Korean populations. Any studies that's outside Korea?
So are you asking about non-invasive tests?
No, EQTL, so the disease-specific EQTL screening.
Yeah, I think that this question for me. Yeah, this is one speaking. Okay. Thank you for your nice question. EQTL. I already showed you many evidence of a Korean biopsy-proven NAFLD code regarding the diagnostic role of new biomarkers in NAFLD patients. For example, in our microbiome analysis data, we found that some pathogenic microbiome species and protective microbiome and other still metabolites can predict the fibrosis severity very accurately in non-obese NAFLD patients rather than in obese NAFLD patients. Those findings were externally validated in using UC San Diego microbiome data available in open source data published by Roy Rumba. So we validate those findings in other ethnic populations, including Caucasian populations already. It was published in Nature Communication last year. And other findings is, for example, we discovered some new polygene risk model for predicting NASH or significant or advanced fibrosis in NAFLD patients. Our new model was validated in Chinese population cohort. He is Dr. Chang Minghua in Zhejiang University. And he validated our findings in their Chinese cohort. So our polygene risk model is working very well, at least in Asian populations, including Korean and Chinese population. And especially for EQTL analysis, we used GWAS for whole genome, whole plus, using whole plus and liver tissue RNA sequencing data in combination for discovering novel risk gene in association with the development or progression of NAFLD. That new technology would be very informative and very helpful for detecting the new druggable targets for anti-NASH drugs, especially for precision, in terms of precision medicine. In this new era of precision medicine, we are considering the precision medicine, especially for non-obese or genetic NAFLD patients, because those patients have less frequency of obesity or metabolic syndrome. So we should focus on the genetic predisposing factor for those patients. And I think that, I don't know, it is ready for priming yet, but I think that at least for Asian populations or genetic NAFLD patients, we should consider the genomic profiling or molecular profiling before initiating a new anti-NASH or antifibrotic drug therapies. I think that the master protocol for validating the new therapies for NASH patients would be available in the near future, because target therapies should be used for each individualized treatment strategy. So I want to discuss these issues with you today. Thank you.
Congratulations. This is really very, very good work. I think this will help to really move forward in the areas of liver disease, not just NASH. In fact, do you have a chance to really look into the implications in cardiovascular disease? I mean, so with the NASH, we know they have an increase in cardiovascular morbidity and mortalities, and whether this screening tools is correlated with outcomes or even further, apart from just the developments of NASH and the liver fibrosis.
Okay. Yeah.
Any, you don't have these correlations, right? Okay.
Okay. Another question or comment? Okay. We are running out of time. So we'll close the discussion time. And today's topic is very interesting, and it was a great time to share opinion through this webinar. So I would like to thank every speakers and with a good presentation and Thank you again, Chairperson and panelists and everybody. Lastly, President Jim Mo Yang will give us a closing remark for us. Please, yes. President Yang, please.
Yes, thank you, Professor Joe. So I'd like to thank to all doctors participating in today's NAFLD webinar. I hope today's NAFLD webinar will help in your clinic and research field. And thanks to chairmen and the speakers for wonderful and institutional presentations. And also thanks to Professor Omata, Professor Sarin, Professor George Rao, Professor Diana, Professor Joganda, Professor Hasimi Kajian, and Professor Young-Sung Lim for your constant support. Last, see you in January next year for the next APASL webinar. So goodbye.
Bye.
Thank you.
Yeah, wonderful.
Bye.
Omata, Japan. One
Thank
of
you,
the
sir.
best. Yes,
Thank
one
you.
of the
Professor
best.
Omata is here.
Sessions.
We need your
Great
comments.
talks. Wonderful. Plenty of talks. I learn a lot. Omata.
Thank you, sir.
Thank you.
Yes, Dr. Wang. Yes, I'll see you next year.
Thank you very much.
Yes,
Bye.
all right, everybody. Good night.
Goodbye.
수고 많으셨습니다, 선생님.
수고하셨습니다.
감사합니다.
Bye bye.
이완수님
Good
수고
night.
많으셨습니다.
Bye.